Next one out, right?
The next one out. So, yeah, thanks, Irvin.
Yeah, I think we have a pretty good crowd. Welcome everybody to Internal Medicine Grand Rounds. It is a pleasure on this very dreary, rainy day to have Dr. Juan Carlos Cardet to make our day so much brighter with his talk today. So Dr. Juan Carlos Cardet is an assistant professor in allergy immunology in our Department of Internal Medicine of our USF Health Morsani College of Medicine. Dr. Cardet graduated from Harvard University with a degree in biology in 2004, followed by then completion of his medical studies at the University of Puerto Rico School of Medicine. He then returned to the Northeast to complete his residency in IM at the University of Connecticut, followed by a clinical research fellowship in rheumatology, allergy, and immunology at Brigham and Women's Hospital. He went full circle, if you will, in his education, going back to Harvard and getting his master's of public health. To say that we were delighted to have Juan Carlos join our faculty would be the understatement of this decade. And Juan Carlos has shined on our faculty here so far, doing outstanding clinical research work and being an outstanding mentor and educator for the fellows in allergy and immunology and providing outstanding care to our patients here at USF Health. Juan Carlos is going to give us a talk that's going to be very exciting today. But I do want to point out and offer congratulations for many of you who have heard. He was co-first author for New England Journal of Medicine recently for the reporting the results of the PREPARE trial, multi-center trial looking at the asthma treatment in Black and Latinx patients, a definitely population that needed to be looked at for asthma care. And so it is a pleasure to introduce Dr. Cardet and Juan Carlos. Thank you for everything you're doing, and we look forward to your talk at Grand Rounds today. Please move ahead, and thanks for being with us.
Wonderful. Thank you so much for the kind words, and thanks for having me. I'm going to share my slides. I'm going to talk to you about cytokines. Can you see them?
Looks good.
Looks great. Thank you, Juan Carlos.
Sounds good. So I'm going to talk to you about cytokines and biomarkers for a disease that I think all of us, in internal medicine, we encounter in clinic: asthma, allergic rhinitis, and atopic dermatitis. And I really hope you find this useful. Here's an outline. For asthma, I really want to focus on blood eosinophils and FeNO, talk to you about this T2 type 2 inflammation, non-type 2 inflammation paradigm. In terms of allergic rhinitis, I'll drill down on that, how that goes, alarmins, ILC2s, T2s, effectors. And for atopic dermatitis, I'll focus on IL-22, 31, CCL17, and IgE. Big disclosure, this is going to be so data heavy, and still it's not going to be an exhaustive list for any of the diseases. I'll try to speak quickly, cover most of the topics. Conflicts of interest disclosure. I've received honoraria for work on advisory boards and giving lectures on asthma, not pushing a product, just talking about asthma for a few pharmaceutical companies. Post-lecture questions. These are issues that I will be talking about throughout the lecture. Keep an eye out from them. It's not the main points, but keep an eye out for them. Neurotoxin, whether or not it's commercially available, what's a PGD2 target that's important in chronic allergic rhinosinusitis, and whether or not it's a good idea to increase IL-22 in atopic derm. So with that, I'll get right into it. This is a busy slide, and it's on purpose. These are important cytokines in asthma. This is now 5 years old, Elliot Israel and Helen Riddell. But it's essentially the same paradigm. It's complicated, but I want you to think about it from top to bottom and from left to right. essentially, you can think about it as that's the airway lumen, and those are the airway epithelial cells. Those every human being encounters antigens, irritants, pollutants, microbes, viruses, right? We face the world. And those epithelial cells, they release, look at those three, TSLP, IL-25, IL-33, so-called alarmins. It's the way that we signal to our system what's going on in the outside world. Those three alarmins, then they engage important cells. ILC2s, innate lymphoid-like cells, T helper cells, and also dendritic cells, not shown there. But they're skewed in response of those alarmins. And if we look at the left half of this picture, they're skewed in a way that they produce these three canonical cytokines for type so-called, that they define type 2 inflammation, IL-4, interleukin-5, and interleukin-13. I'll talk about those in details later. Those, in turn, have effects on B cells. They start making IgE as opposed to IgG. They lead to skewing of T helper cells into Th2 type paradigm, so a feed forward on that. In turn, those cells lead to engagement of other cells that are called effector cells that then produce important cytokines and chemicals like glucotrienes, histamines, other mediators that lead to the typical features, defining features of asthma: hyperresponsiveness, airway remodeling, mucus production, airway smooth muscle constriction, and hypertrophy. And then the left-right paradigm is type 2 inflammation. I talked about just now. And non-type 2 inflammation, because we see that over half of patients with severe asthma, they also have this non-type 2 inflammation that seems to be important in asthma. IL-6 is an important one. IL-17 leads to neutrophilic inflammation that we see many of these patients have, and also lead to the stereotypical features of asthma. So let's start with the alarmins, just like that. In the last slide, from top to bottom, left to right, let's go like that. So here's one of them, thymic stromal lymphopoietin, TSLP. It heterodimerizes with the TSLP receptor with the IL-7 receptor alpha. IL-7, as you know, is super important in T cell biology. This complicated slide, essentially, it's, again, the outside world gives you stimuli, engages epithelial cells, but also mast cells, fibroblasts, keratinocytes, which release TSLP, which is pluripotent on many of these cells that are important in asthma. One thing, I started circling them, which ones are important in asthma, but that's a mistake. Essentially, all of them, you can implicate them in asthma. One thing that in the field in asthma we have seen is that many of these cytokines and mediators that I just showed you a second ago, we now have targeted monoclonal biologic therapies, so monoclonal antibodies that bind these specific mediators. And since they're so important in driving asthma, we have seen that many of them actually make people with asthma feel better. So I'm going to show you very recent large phase 3 clinical trial results that appeared within the past year. And one of them is for Tessepalimab, which is one that's against monoclonal antibody against TSLP. It's a phase 3. What I'm showing you is a phase 3 trial that appeared late in last year, New England Journal. More than 1,000 people across the age ranges, teenagers up to adults up to 80 years. Medium to high dose inhaled corticosteroids plus a second controller. So asthma severity, high asthma severity, every 4 weeks subcutaneous injection of this therapy, Tessepalimab. And as it's usual in these trials, it's a year-long study because you want to have enough time to observe asthma exacerbation to occur. They did not detect an oral corticosteroid sparing effect, but they did see about a 50% reduction in asthma exacerbations. What you're seeing on screen, it's called an interaction analysis. So essentially, they wanted to see, is the effect better in people who have eosinophils less than 300 or more than 300, eosinophil counts at baseline, FeNO, I'll talk to you about those, whether or not they're allergic. And you can see essentially that every single 95% confidence interval, and that effect marker is to the left of the line of equivalence at 1.0 of the vertical line, which means Tessepalimab is better. So not every biologic that's out there has had those results, especially with eosinophils and FeNO, but this one seems to work in all of them. The other alarmant one of the other alarmants that I showed you was interleukin 33. You can see that this one, it's the ST2 ligand heterodimerizing with the interleukin 1 receptor A. Interleukin 33 is in the same family as that interleukin 1 cytokine, and you can see that the downstream signaling activates transcription factors, MAP kinase, and NF-kappa B, which leads to gene expression. Like the TSLP slide, you can see the outside world stimulates epithelial, but also endothelial stromal cells, which produce interleukin 33, which again is pluripotent and has many effects on different cells important in asthma. And there's a clinical trial for that. Late last year, Mike Wexler and others, they published in New England Journal this paper, which is unique because it's, as far as I can tell, one of the first times that they combine different biologics. I'll show you that in the next slide, but they wanted to see the effects of an anti-IL-33, Atopic, and an anti-IL-4/13 receptor. Remember that IL-4 and 13 is part of that type 2 inflammation that I talked to you about, and whether that combination of therapy was superior to either one alone. I'll show you the results now. I wanted to spend some time in the trial design because this is unique. Notice that the trial duration, look at the follow-up, right? That ends at week 12. This is unusual. This is a phase 2, so it's earlier phase, much smaller, 296 people. So that's not enough time to observe asthma exacerbations occur, right? So what they did was an inhaled glucocorticoid taper. You notice that from week 6 to 9, and then no background therapy, which is astounding how they managed to design this trial among teenagers up to adults 70 years of age with medium to high dose ICS inhaled corticosteroids and a second inhaler or controller, long-acting beta agonist. So they managed to remove all control therapy on these people to induce a loss of asthma control, which again is not the same thing as an asthma exacerbation, which is defined as a worsening of asthma control that requires oral or systemic corticosteroids to control it. So for this outcome, which is different, loss of asthma control, they could count it as reduction in 30% in peak flow, 2 straight days, or using 6+ rescue puffs of rescue inhaler for asthma on 2 straight days. So not the same, slightly different. And what we see is that relative to placebo, all of them were better. So both the combination of itepekimab and dupilumab was better, but also the anti-IL-33 was better at reducing the loss of asthma control, and also dupilumab. There was no significant difference between IL-33 and dupilumab alone, and it looks like they were slightly better than that combination, suggesting there's no really bang for your buck in combining the two of these drugs like they thought they would. And so that's, at least for now, at least looking at that outcome of loss of asthma control. Another trial on that pathway, this one not interleukin 33, the cytokine, but its receptor. It's a phase 2 trial, and you can see this one was a year-long study, similar population, adults only, 502 of them, uncontrolled, that's what it means, that having an ACQ score of more than 1.5. And you can see that the highest dose of 490 milligrams of astegolimab was the one that had the greatest impact in reducing asthma exacerbation rates. You can see that in the lilac color relative to the others, and especially placebo. This is in terms of FEV1, though. You can see asthma exacerbation rate reduction above and improvement in FEV1, about the same as we have seen with other biologics, especially dupilumab, that 200 cc improvement in FEV1. So this one is to talk more about interleukin-4, 13, and one of the biologics for them. You can see that both interleukin-4 and 13 share that interleukin-4 receptor alpha. The gamma common receptor is for the interleukin-4 receptor, whereas the interleukin-13 has its specific receptor, interleukin-13 receptor alpha-1. They're both heterodimers, right? So interleukin-4 is very important, as I mentioned before, isotype switching for B cells to make IgE, skewing of T helper cells towards Th2-ness, and in airway smooth muscle, hypertrophy and of airway smooth muscle, which is characteristic of asthma. You can see the signaling cascade there, and it follows a JAK-STAT signaling pathway, as many of these cytokines do. Most recently, Len Beccarier and others published in the New England Journal, again, last year. Dupilumab was already in the market. It's for adults. Then it became available for teenagers. But now it's available for children. It's going to become available for children based on these data. You can see this similar interaction analysis. Panel A, B, and C is for asthma exacerbations. FEV1, so lung function, and asthma-controlled scores in terms of ACQ-7. And you can see that they're all pointing at dupilumab being better than placebo and having a similar reduction in asthma exacerbations as we have seen before in other populations, other age ranges. Here we can see that it's regardless of that type 2 inflammatory phenotype, as you can see those categories there. The other cytokine that's important in type 2-ness is IL-5. If you want to think of IL-5, think of eosinophils. It's everything related to eosinophils. Th2 cells, ILC2s, mast cells, eosinophils, they make IL-5, which cause eosinophilpoiesis in the bone marrow, chemotaxis, extravasation, maturation, activation, everything. So we have two monoclonal antibodies that target IL-5 itself, Meppolismab, which came first into the market, then Rhinitis, and there's also the interleukin-5 receptor alpha, which is Benralizumab, which depletes eosinophils, but also it's expressed, that receptor is expressed in basophils, so it targets basophils themselves. Eosinophils make all those granule proteins and mediators act on pulmonary structural cells and cause features of asthma, and you can see the signaling cascade there. This is from a meta-analysis by a task force of the European Respiratory Society, American Thoracic Society, showing meta-analysis of several phase 2 and phase 3 trials on Meppolismab relative to placebo. And in aggregate, it's what we have seen, about a 50% reduction in asthma exacerbation rates relative to placebo among patients with moderate severe persistent asthma. This is a review by one of our junior faculty members with allergy, Stephanie Huddy, and others from the division. We wrote this on non-T2 asthma. What I'm highlighting is that the Th17 pathway seems to be important with secretion of IL-17 and 6, promotion of neutrophil infiltration in the airways. So last year, Chris Breitling and others published this monoclonal antibody therapy. It's called risankizumab, targeting IL-23, which is important because it skews naive T helper cells into Th17 cells, which I just said is important in non-T2 asthma. And it was significant, but if you notice, in the x-axis is time, and the y-axis percentage of patients without asthma worsening, and placebo was superior to risankizumab. So it had the opposite effect. It might be worsening patients. We don't want to go there. We had tried, the field had tried this before. Bill Bussey and others had tried the anti-IL-17 brodalumab, and it also failed to have any significant benefit in terms of asthma exacerbations. For this one, they wanted to see, well, is the point that we should enriched these clinical trials with people with non-T2 asthma, and they got sputum induction samples. And they saw that there was target engagement, there was downregulation and predicted inhibition in pathways related to anti-IL-23. But even in those selecting, doing a stratified analysis and selecting those people who had a high peripheral sputum neutrophils, those didn't do better either. They did just as poorly as others. So we're not going to take this into our strategies. Those are the cytokines. Let me talk to you a little bit about biomarkers. I think this one is especially helpful in asthma, less so. I have nothing especially novel for allergic rhinitis, which I'll get to later in the talk, or about some for atopic dermatitis, but much more clinically useful and available right now for asthma. So what is a biomarker? This is an old definition from the NIH, but it's still valid. It's a characteristic that is objectively measured and is evaluated and is an indicator of normal biologic processes, pathogenic processes, or pharmacologic responses. That's exactly what we want to get. We want, what is a lab that I can get on my patient that can tell me something about the disease, either diagnose it, support the diagnosis, or help me predict how bad it's going to be, how long it's going to be active, or tell me what is a specific therapy that's going to be helpful for my patient, for the person who's sitting across from me in clinic. Maybe not the next person, but this person. And can I avoid having side effects or using therapies that are have more side effects if I have more information from this biomarker? And ideally, this is cheap. It's not going to be something that requires a bronchoscopy to get, non-invasive, and it's accurate and discriminating. It's this and it's not that. And that's all of those. That's like a dream list, but it's very hard to get. One of them, we do this in allergy routinely in clinic. It's FeNO, fractional exhaled nitric oxide. It's synthesized by airway epithelial inducible nitric oxide synthase. It correlates with airways eosinophilic inflammation up to a certain degree. I can tell you maybe after the lecture, email me or something, how well it does and when it doesn't. Standardized methodology, established reference ranges, and it's non-invasive. It's literally like that picture you're seeing there. It's a yay-sized machine. In 30 seconds, you get the answer, and it's pretty cheap. It's non-specific for asthma. One of our study coordinators, he had levels always in the 300s. Above 50 is high. He had 300s. He didn't have asthma. He just had like bad allergies, like allergic rhinitis. It can be expensive, depending on different models and where you live. It has an unclear relationship to asthma phenotypes. As I told you before, there's different kinds of asthma phenotypes: type 2 high, non-type 2 high, and whether or not it has a relationship to airway remodeling, which is an untackled a situation with asthma. Many patients have difficulty using the machine. You need to breathe at a certain flow, and some people can never get to it. I'm presenting you this in part because expert panel review from NIH and HLBI came out in December 2020 with these recommendations. So I'll go through them. The first two are positive ones and second two are negative ones. And here's what I mean. First one, conditional moderate strength. For patients 5 years and older with an unclear asthma diagnosis, use it as an adjunct evaluation, not to replace other criteria, but as an adjunct. It can help you. For those with persistent allergic asthma, you can use to monitor and manage the strategy, as opposed to, and here's recommendation 3, don't use it alone to assess asthma control. Use your clinical skills to do that. Predict future exacerbations or assess exacerbation severity, right? For patients less than 5 years old, don't use it to predict the future development of asthma, and that's a strong recommendation. And some caveats. What made it into the guidelines recently is data not related to biologics, and then I'm going to show you some data related to biologics in the next few slides. they suggest monitoring. If you're going to use this as a strategy, keep monitoring over time, like every 3 months or so. The main effects are on exacerbations, not symptoms, and I'll show you that on why that's the case, or adherence to ICS. But I think there's a wink in that one, because the latter is what most of us use, use FeNO for. I think most of us use the recommendation from ATS guidelines on FeNO from the early 2000s, saying that anything that's FeNO greater than 50 is more likely to respond to inhaled corticosteroids, and suggests that your patient is not really using inhaled corticosteroids. And there's some data to suggest that's the case. Here's why the effect is mostly on exacerbations. The paper in JACI in Practice it's old now, 2013, primary care sites, outcome was exacerbations, and you can see that there's a substantial difference, a p less than 0.03 for an FeNO guided strategy for asthma control therapy relative to control and using standard measures of titrating control therapy. Whereas this is from the ACRN, NHLBI ACRN network, you can see the biomarker-based adjustment curve, that BBA, that's FeNO really. It was not superior to the other ones, including the physician assessment-based adjustment biomarker, or the symptom-based adjustment. But in that one, they were looking at treatment failures. So like the Mike Wexler trial on the anti-IL-33, there's a difference between outcome treatment as treatment failures, which is more like includes loss of asthma control, versus noticing an exacerbation. Maybe this trial would have been positive, or this analysis would have been positive, if maybe the sample size was bigger for each arm, or they looked at exacerbations. That's speculation there. And this is in terms of guiding monoclonal therapy. This is for Dupilumab, and you can see that in that top figure, it's also an interaction analysis. The one that shows the greatest reduction in exacerbations relative to the other biomarkers, eosinophils or the other FeNO levels, are for individuals with FeNO greater than 50 parts per billion, favoring Dupilumab, fewer exacerbations. And you can see that there's also a response to therapy. And I'm putting it in red. For both doses, the 200 milligrams and the 300 milligram, there's about a 15-point reduction, or almost 16-point reduction with Dupilumab, whereas placebo, it was only 2.5, 3 or 4. In contrast, that's what happens with Dupilumab. Dupilumab decreases FeNO, but other monoclonal antibodies in that similar pathway, the T2 pathway, like the anti-IL-5s, they don't touch it. They don't touch FeNO, and FeNO doesn't predict a response. Omalizumab is an anti-IgE, which is important in allergy. It does decrease FeNO, and FeNO also predicts its response to omalizumab. And our own Tom Casale has done a lot of work on omalizumab and its prediction, how to predict responses to it. So this one, just to get to the post-lecture questions, this one is not commercially available, and this is not in clinical practice, and a lot of people are looking for better biomarkers than just FeNO and blood eosinophils, of which I'll tell you in a second. So there's consideration that maybe this could be better. Why? So eosinophil-derived neurotoxin is a cytotoxic protein found in eosinophil granules. It's a marker of eosinophil activation, and the hypothesis is that there's active eosinophils and inactive eosinophils. It's likely that active eosinophils are a better marker of asthma severity and disease, and are going to be better predictors for these monoclonal antibodies than total number of eosinophils, which includes inactive eosinophils. So recently in that +1 paper, and the disclosure here is that every single author is an employee of the AstraZeneca pharmaceutical company. But something neat that they did, and something that's needed if you're going to take into consideration any biomarker, is that they established a reference range in healthy populations of adults up to 75 years of age. They found it doesn't differ by sex, smoking status, circadian rhythm, right? You can have people show up to Quest or LabCorp or TGH SunQuest, whatever time of day, there's not going to be a large diurnal variation. Storage material or temperature, that's useful. But it's not routinely measured right now. Here's the data and whether or not it helps. I don't think it helps. I'll cut to the chase. From the European cohorts, EGEA 2 and 3, it associates with persistent asthma and current symptoms in longitudinal follow-up. Is that helpful? Not to me. Persistent asthma and current symptoms defined as you wheezed in the past month once. I can ask somebody and they can tell me whether or not they wheezed in the past month. Therefore, I don't want to do a test that's going to cost $50 or something to find something that I can find out by talking, right? So what else? What other data we have from a cross-sectional study from South Korea, 75 uncontrolled asthmatics, 56 controlled, and 43 healthy controls. You can see that the area under the curve for EDN beats the threshold of usefulness of 0.7. Here it's 0.726, and it predicts if there's an EDN high enough above a threshold that they define, it associates with uncontrolled asthma. Again, not very useful. You can ask somebody right now an ACT score. It takes you 30 seconds to fill it out, and you can find out the same information. From a cross-sectional Swedish study by Mogensen and others in 2019, they showed that this is not blood, this one's urine. I don't know if there's a big difference. This is sort of mixing apples and oranges, but we'll see. Urine EDN associates with persistent airflow obstruction, defined as you can see there on screen, while FeNO, serum periostin, eosinophil cationic protein, other markers of type 2 inflammation do not. But and this is from Peter Howarth and other employees from GSK now. They published this late in 2020 in Allergy that baseline blood eosinophils were better than eosinophil-derived neurotoxin at predicting responses to Meppolismab using data from the Mensa phase 3 trial on Meppolismab. That's the sort of information I think at this point we're looking for. But it turns out a blood eosinophil count that's commercially available widely in terms of a CBC, and it's relatively cheap, can outperform this fancy new potential player in the game. So we're not going with it. So more information about peripheral blood eosinophils with that a preamble with the other one. It's widely used as a selection biomarker for existing asthma biologics. It's sort of concordant with sputum eosinophils, which are better reflective of the target organ, sputum, induced sputum, and then the lung, right? But you can see from Fowler and others that if you look at the sensitivity for eosinophils above 450 per microliter, it's down to 49%. If you look at that middle threshold, sensitivity is 60%, specificity is like 84%. It's not perfect. There's a correlation for sure, but it's not perfect. This study, the data I'm going to show you now, it's mostly from David Price and his group from the UK/Singapore. The top one, they're great at doing very large database analyses. This one is from the UK, more than 130,000 people with asthma, blood eosinophil data available, and 2 years prospective follow-ups. We cite this a lot, in the field. Those with eosinophils greater than 400, they have 42% greater rates of severe exacerbations, 28% greater rates of acute respiratory events, 22% better asthma control, 22 to 26% better asthma control in its many different domains after all the adjustments that you can see on screen. More recently, his group last year published a follow-up, slightly larger database, but it gets to the issue of people vary over time. What is the stability of this biomarker, blood eosinophils, over time? So they segregated the population, as you can see, defined as on screen, into never eosinophil high, intermittently eosinophil high, or persistently eosinophil high. And essentially, both intermittently and persistently high groups had a greater risk of asthma exacerbations with a similar effect size as what I showed you in the earlier study. And Monica Kraft and others late last year in the European Respiratory Journal, they pulled data from 6 similar industry-sponsored monoclonal antibody randomized controlled trials and showed that blood eosinophil is one of the strongest predictors of asthma exacerbations, beating out many of the other biomarkers. So it's still one of the best things we got. This idea, this is from Tom Casale. This is look at the DREAM study for Meppolismab, top left. Look at the Omalizumab pivotal trials, and look at the Dupilumab trials to the bottom right. You can see that the top curve is for the placebo arm. This really shows how there's a heterogeneity in asthma and how blood eosinophils can pick it up. You can see in the x-axis, it's essentially identical for all 3 figures. It shows baseline eosinophil count. In the y-axis, it's a number of exacerbations. Look at the dose response that it shows. The higher the number of eosinophil counts in people taking placebo, the higher it's from the bottommost to the topmost. It's about a 2-fold difference, right, in the number of exacerbations, which is pretty huge. You can use this in clinic. So combining blood eosinophils and FeNO, does it do anything? So Couillard and others last year in thorax, they made this complex figure, but I think we can narrow it down by looking at 2 points and comparing them. Again, this is like data from industry monoclonal antibody trials. Comparing people at the bottom leftmost who are essentially asthma attack in the last year, no asthma attack in the last year, who do not have clinical risk factors, which include having comorbidities and being exposed to smoke or allergens or pollution, being intubated in the past. These were some of the clinical risk factors that they defined. That's the asterisk. Not having those, being at GINA steps 1 and 2, so the lowest of the inhaled corticosteroid levels for maintenance, and having eosinophils less than 150 and an FeNO less than 25, the expected number of asthma exacerbations in the next year is 0.06, green light. For those who had an asthma attack in the last year, are on, let's have 2 or more clinical risk factors, let's say they smoke and they have hypertension and diabetes, who are on GINA step 5, so let's say ICS, long-acting beta agonist, and tiotropium, long-acting muscarinic antagonist, who have FeNO greater than 50 and a blood eosinophil count more than 300 per microliter, the expectation is to have 2.6 exacerbations in the next year. I think this is useful. So switching gears. I need to speed it up. There's a lot of information. So cytokines important in chronic allergic rhinitis. The main point, there's a lot of overlap with asthma. Essentially the same paradigm. Lumen, external world, interacts. Allergens and other stuff like that interact with the epithelial cells. They release those 3 alarmins. They engage a bunch of cells, ILCs and T helper cells. ILCs become ILC2s. They affect mast cells, which with some of their cytokines, which secrete PGD2, which activates eosinophils. That's one of the post-test questions. In the field, we've now focused on nasal local type 2 inflammatory response. For example, people who skin prick test or serum Ig test only to seasonal pollens, yet have perennial symptoms. But doing local immunity, let's say finding evidence of sensitization only in nose, that's not really clinically available yet. This is from Steeland and others. That same pathway I wanted to show you, interleukin-4, which is secreted by many of the cell types that I mentioned before, including T helper 2 cells, act on airway epithelial cells and disrupt many of the epithelial barrier proteins, and leads to it's the features seen in asthma, for example, not in asthma, allergic rhinitis, such as nasal secretions, and distinguishes it from idiopathic rhinitis. These are two busy slides, but the effect essentially is to decrease those of interleukin-4 and other chronic allergic rhinitis important cytokines, is to disrupt the nasal epithelial barrier by effects on tight junctions, adherence junctions, desmosomes, and hemidesmosomes. What's new in the field is that ILC2s are important in chronic allergic rhinitis. You can see in the leftmost graph that from blood, not local tissue, from blood, individuals with allergic rhinitis have more cis-LT1 receptor positive ILC2s than those with healthy controls. And when stimulated with LTD4, these produce interleukin-5 and interleukin-13, which I showed you before, are important in type 2 immunity, and these are somewhat decreased by montelukast, which is commercially available, and by inhaled corticosteroids, intranasal corticosteroids, such as budesonide, also commercially available. That's from a paper by Chin and others in Allergy 2020. This one is from 2019. This one is ILC2s in intranasal tissues being higher in those individuals with Haus-Stussmann-induced allergic rhinitis relative to controls. And in a similar paradigm, those stimulated by PGD2, those cells, blood-derived ILC2s from allergic rhinitis relative to those with that are healthy controls, there is an increase in IL-5 production, which again, type 2 cytokine, important in chronic allergic rhinitis, but it's derived from these cells. These cells are now important also in chronic allergic rhinitis. So finally, and I don't have a biomarker for you to show you for chronic allergic rhinitis. We typically do skin prick, standard practice, skin prick testing for relevant aeroallergens, especially ones that are important here in Tampa. And we're getting better and better in terms of the sensitivity and specificity of these results when you do serum allergen-specific IgE, and you can get those from Quest and LabCorp. But there's no other biomarker that I'm going to tell you, oh yeah, this is going to skew your treatment algorithm one way or another. So last one, atopic dermatitis, cytokines, and then biomarkers. You can see that this is slightly more complex than that paradigm pictures that I showed you for both asthma and allergic rhinitis. Here we have different cell types depending on non-lesional skin versus acute stage of atopic derm versus chronic stage. We see in red some of the biomarkers we saw before for the other two diseases, but now I'm putting in blue interleukin-22 and interleukin-31, and I'm going to talk to you about in a second. So interleukin-22, you can go from top left. It's secreted by type helper T helper 2 cell 22 cells, which secrete IL-22, which is important in creating abnormal keratinocyte proliferation and differentiation and other markers of a chronic stage of atopic derm. You can see the types of receptors that it engages and the signaling pathway by JAK and TIKES and STATs, and having effects on transcription factors AKT and mTOR. So, and you can see in the bottom panels that there's a dose response effect between IL-22 and the thickness of keratinocytes. And you can see also in that histologic H&E analysis where there's increased thickness of the keratinocytes with exposure to IL-22. From Renert Yuval's group, there's a lot of good work coming from that group in atopic dermatitis. You can see that Th22, IL-22 levels from skin across the age ranges. Look at the panels: infants, children, adolescents, and adults. There's a distinguishing feature between control skin and non-lesional skin and lesional skin in terms of IL-22 levels. And they seem to correlate well with atopic dermatitis scores, severity scores. Look at for children in lesional skin, p-value is significant, but a row greater than 0.4, sometimes 0.5, is considered to be a strong correlation. So it's strongly correlated with lesional skin in children. It's also the case in adolescents. So maybe that's useful. I'll tell you more about that in a second. The other one is interleukin 31. It's produced by those cells shown above, many of those important in type 2 immunity, such as eosinophils, basophils, mast cells, but also more local structural cells important in atopic derm, keratinocytes, fibroblasts, T cells, macrophages. Look at it's another heterodimer, interleukin 31 with OSM-R beta. Engagement of those receptors leads to that signaling cascade and leads to pro-inflammatory cytokine secretion, cell migration, anti-proliferation, and proliferation, depending on the context. Induction, that's the main one. IL-31, think of induction of pruritus. That's the main thing that I would like you to focus on. And of Meng and others in JCI in 2018, they showed this paper, and I think this is important, which is the intersection between pruritus and atopic derm. And you can see that interleukin 31, which is released by those cells that I'm showing you above, engages its receptor in the dorsal root ganglion. So here's the pruritus part of it. But part of the mechanism is through the release of brain natriuretic peptide, which engages receptors in keratinocytes and leads to increases of those mediators, and which leads to the features of atopic dermatitis. And you can see that exposure of interleukin 31 leads to that dose response effect on releasing BNP. This is from many of the experts in atopic dermatitis got together and put together a paper for biomarkers in atopic dermatitis, and they look at 3 different domains. One, distinguishing biomarkers versus another somewhat similar disease, psoriasis. They found that the main 2 ones were INOS, inducible nitric oxide synthase 2, found it to be high in psoriasis and low in atopic dermatitis. That's exactly the sort of thing that you want from a biomarker. Help you distinguish it's this and it's not that. The other one is CCL27, which is high in atopic dermatitis but low in psoriasis. This is not clinically available yet. And then monitoring serum biomarker for disease severity, like I showed you before, that correlation with that SCORAD. And the criteria was correlation needed to be strong enough, that rho value greater than or equal to 0.4, p-value, the tyranny of the 0.05, and having 5 or more publications, and whatever that has an asterisk, they showed, or they thought as a consensus panel, that they have high or very high overall evidence for biomarker generalizability based on sample sizes of the different studies and heterogeneity of the population study. And finally, a therapeutic response biomarker, they listed those, CCL17 and CCL22. Of those, I'm going to choose 2 to show you to you now. These are the last 2 slides that I have. The main CCL17 and IgE. CCL17 less so clinically available, but we might be getting there for atopic dermatitis. And this is in children. You can see that they first looked at, what if we also look at those who are sensitized to food allergens, which is a common comorbidity, especially in children with atopic dermatitis, food allergies with atopic dermatitis. You can see that those who are sensitized, that rho value, remember that 0.4 and greater is strong. those were sensitized at 0.65, right? And and that's the correlation with that SCORAD, which is a score for severity of atopic dermatitis involvement. We can also see a similar situation, less strong, but still strong, 0.59 when it's sensitization to airborne allergens. And then the right half of this slide, you can see the results from Zidane and others, a little bit old now, 2015, but you can see that total serum IgE, which is very commercially available, is much higher in individuals who have atopic dermatitis relative to those with control. And in the B, the lower panel, that there's a dose response. Those who with mild have higher than controls, moderate more than mild, severe more than moderate. You can see that the correlation, that row correlation between total IgE and that SCORAD atopic dermatitis severity scale is very high at 0.9, and it's significant. So in summary, blood eosinophils and FeNO are important treatment selection and response biomarkers for asthma. I gave you a lot of data on that. ILC2s have a role now in a type 2 inflammatory paradigm that's present in allergic rhinitis, and IgE and CCL17, sorry for the typo, may be supportive biomarkers for atopic dermatitis, but not yet. Post-lecture questions. So EDN is not yet commercially available, so false. IL-9 stimulated mast cell-derived PGD2 in the nasal milieu is important in the pathophysiology of chronic allergic rhinitis by activating eosinophils. And strategies aimed at increasing systemic IL-22 are likely to be good for atopic dermatitis false. They're likely to exacerbate it. Nobody would dream doing that. These are my references. I think I skipped a bunch. I can provide you any other references that you need. And I'll take any questions now.
Thank you, Juan Carlos. That was outstanding and excellent reference list there. Really appreciate your thoroughness and attention to detail. Really has, highlighted why we're so excited you are here at USF, Department of Internal Medicine. So I'm going to go first to Dr. Ledford. He was averaging a question every 3 minutes there for a while. So Dennis, why don't you highlight some of the questions you had a little bit earlier?
I don't know if you can hear me. I'm in a noisy place, but thanks, JC. I think it's hard as internists, because we deal with so many diseases, to be aware of the transition of understanding of the pathogenesis of chronic problems. I mean, think of 7 to 30% of every patient you see in clinic has one of these diseases, 7 to 30%. So you can see it is relevant to internal medicine. But I was just curious if you feel these signatures that you described are consistent over time. How do we know if a patient who's 5 versus 30 versus 50, or who's a viral infection versus having a reaction to a food, do these signatures all change, or do you think they're actually genetically linked to the person, meaning they stay the same regardless of time, place, and circumstance?
I think you've asked me that question before. My answer is usually limited. I think we have limited information about that. I think SARP-3 and now SARP-4 are one of the few instances that we've tried to address that question. I think the paper that came out by Michael Peters and others on IL-6 and eosinophils, they show there are some individuals that remain exacerbation prone every single year after a 3-year monitoring of their asthma exacerbation proneness. Within that exacerbation proneness, and let's define it as 2 exacerbations per year, there's a bunch of people who remain eosinophil high, defined as blood eosinophils greater than 300, persistently so every single year. The other phenotype that's coming out of Mike Peters' lab is that IL-6 high, right? That non-T2 pathway there's a subset of individuals, not everybody, that remains persistently IL-6 high, right? But it's not everybody. IL-6 and eosinophils, they seem to be independent predictors for exacerbation proneness. I think the data that I showed you by David Price's group about the stability of the blood eosinophils being greater than 300 persistently through time, I think a minority of people are never eosinophil high. I think that was about 20%. I think there's a good portion, about 40-something%, who are intermittently eosinophil high, and then there's like another 40% that's persistently eosinophil high. Then the other problem that you're getting at, that you pointed out, is that whether or not this is genetic, and how much do genetics determine the phenotypic profile. I think we're getting better at that, but not yet. I think we have a lot of information on childhood asthma, right? But we also know that childhood asthma, the majority of people outgrow that asthma. Only a minority remains a child with severe asthma who grow up to continue being a severely asthmatic adult. And whether or not we can tell who those individuals are going to be, and whether that's genetically driven, then I don't know. What are your thoughts on that also?
I just think it's important for everyone to understand that these things are many times defined by a point in time, but in other cases have been done over long-term studies. And I think you've given the gestalt, which I think is very important, that it does seem to be a consistent pattern over time, even though multiple triggers are involved. And the last question I'll ask has to do with your study that was published in the New England Journal. That's a very simple idea of using variable dosing inhaled steroids, very inexpensive, very low resource utilization. Do you feel like everyone should try that prior to considering a biologic? In other words, should we always seek a more effective use of our old medications, such as you showed in the New England Journal paper, versus going to a biologic? And can you kind of frame that question for us as to how you in clinic decide whether variable dosing inhaled steroids would be my recommendation versus giving someone a very expensive, relatively expensive biologic? Thank you.
Thank you for asking that question. I mean, we're excited. We're all very excited about that trial, especially since it's such a simple strategy, and it's a low cost of the system. And I think we all see it in our clinic patients. There's a problem with controller therapy for asthma, right? It's people don't like to take their medicines when they don't have any symptoms. Yet that's exactly what we're asking them to do. It's take this inhaler every single day, even if you feel absolutely no symptoms. That's a hard sell. I feel that every single one of my patients in clinic, they sort of want to tell me, yeah, I'll do what you're saying, but they don't want to do that. And actually they don't do that. It's adherence to asthma controller therapy based on refills is down to 25%. So I think it's easier to have the mindset, okay, I'm going to start with an inhaled corticosteroid. Oh, that didn't work. I'm going to up it to inhaled corticosteroid with long-acting beta agonist. Oh, that didn't work. I'm going to add on something else like a long-acting muscarinic antagonist. There's triple therapy for it. I'm going to ask this person to use it. And if that doesn't work, then I'm going to add the $50,000 per year biologic drug. And whether or not that's the right approach, I think it might not be. And this, I'm going to remind everybody, so the PARDIC study, the PCORI trial that we got into the New England Journal recently, it's called a PARDIC strategy, which is patient-activated, reliever-triggered, inhaled corticosteroids. Essentially, keep doing whatever it is that your doctor tells you to do in clinic, but whenever you use anything that you use for rescue therapy, be it albuterol, ipratropium, or a combination of the two, be it by inhaler or by nebulizer, puff yourself with this inhaled corticosteroid that we are going to provide for you for free for the duration of the trial. In that trial, we used a QVAR, so beclomethasone, but we really have no reason to think that it's going to be unique to beclomethasone, right? Any inhaled corticosteroid. It's about patients don't really like to use controller therapy. They're going to use it down to 25% of what we expect them to do or we ask them to do, but they will have asthma symptoms. When they have asthma symptoms, they usually only use a beta agonist, which does nothing for the inflammatory component. And we know that not using inhaled corticosteroids is a risk factor for asthma-related death. So this is a way of using human behavior and autonomous ways of thinking and algorithm that patients use to get the inhaled corticosteroids in their system exactly when it's triggered by symptoms and when their own system is asking them to use it. We demonstrated a 15% reduction in asthma exacerbations. This is similar to the SMART therapy, so using budesonide formoterol in a single maintenance inhaler plus rescue inhaler. The problem with SMART therapy is first trial came out in 2005. It's yet to be able to be found in clinic. It's insurance companies don't pay for it. FDA cautions against budesonide formoterol for rescues. So this goes around that issue. It's keep doing whatever it is that you're doing. Keep using your controller therapy. We're going to use this QVAR whenever you use rescue therapy. You're going to get we're going to see a reduction in asthma exacerbations, similar to what's endorsed by similar strategies, but this one seems to be more feasible and implementable. And maybe this is a way to not have to rely on biologics. That's a long-winded answer, but
I think we could take one more, although we have our chair. So first I'll go to our chair, John Sinnott. Otherwise, I'm not going to be vice chair much longer. Dr. Sinnott?
What an elegant, sophisticated presentation. I'm trying to reconcile this a little bit with post-infectious airway reactivity. I just want to clarify in my mind that that's essentially triggered by IL-13, but the IL-13 actually comes from the innate lymphoid cells. And the innate lymphoid cells are actually very primitive. They don't exhibit B or T markers. Am I correct in my thinking?
I think there's models now that implicate ILCs and IL-13, as you're saying, in viral-induced asthma models. Yes, correct.
Okay, that was my question. Thank you. And is that the post-viral cough that people get that doesn't respond to steroids?
I'm not sure that I can say it's the same, since we can find differences between asthma and post-viral cough. I think there's a lot of overlap, but I think there's distinguishing pathways between the two.
Thank you very much. I've been trying to figure it out with no luck. Great talk.
Thank you.
All right, we'll take one more question and then we'll close it out. No? There we go. Go ahead.
Hey, I'm Jen. I'm one of the general internists at Morsani. I actually work 2 seats down from Dr. T and frequently realize I really have a low concept of what you guys are capable of doing. So my question that came up for me was like similar to what Dr. Ledford said. A lot of individuals with have asthma and chronic allergic rhinitis. And at what point in management do you want us to start thinking about referring them to you. I'm sure there are not enough allergists available for the number of individuals who suffer from these conditions. So I don't know if you have some advice for residents and the just general internists and other specialists out there of like when should we think about sending someone to you?
I think when controller therapy regimens start getting complex, I think when patients have asthma exacerbations, I think that should be a trigger for us. We're more than happy to see them. I think if you observe an association between allergy triggers and loss of asthma control or loss of control of rhinitis, there's many things that we can do about that. We can be of great help. I don't know if some of my colleagues like more indications, but at least those three, we'd be more than happy to see them.
Awesome, thanks. Can I indulge in one more short question?
Of course.
If you have time.
Yeah.
Another question just for general internists. Now that we're starting to see more patients on these biologics, I feel much more comfortable with the side effects with the biologics for oncology patients, but are there specific side effects that we should be watching? You know, we have a patient come in that we should think, oh, maybe this is from one of the medications you're getting from allergy and immunology. Anything we should look out for that's maybe different or the same from the oncology biologics?
I think one of the main ones, there's the Dupilumab that I mentioned. That's the one that targets the common receptor for interleukin-4 and interleukin-13. Many of these people get a substantial portion of these people get high eosinophil numbers. So those need to be monitored. The patient may not feel anything. It's just something that they monitor in their with their CBCs. And many of those people also, regardless of the eosinophil count, but many patients get conjunctivitis, especially those that have atopic dermatitis.
Thank you.
IL-5 and eosinophils in general, they're important in anti-parasitic immunity. Not that I'm aware of, I don't think we have seen an uptick in parasitic infections in this country based on use of anti-IL-5 directed therapies. And other than that, there's a risk of anaphylaxis with some of the monoclonals that we use, but to circumvent that, we administer them in clinic and monitor for the first few injections. So nothing that over the long run you would be seeing them in returning patients to your clinic. It's certainly them having those symptoms.
All right, thank you very much. So we'll end with this. Thank you for, as you can see, the extended period of questions. Everyone very excited about this. JC, fantastic job. And
Awesome.
everybody have a great Thursday. Take care.
You too.